Hello, my name is Omar Awan, and I'm an associate professor of radiology at the University of Maryland Medical Center. Today, I'd like to give a short, hopefully 30 minutes or less, didactic session on evaluation of musculoskeletal soft tissue tumors. I feel like this is a topic that some trainees struggle with, so I wanted to give a systematic approach on how we assess musculoskeletal soft tissue tumors. And I'd like to start all of my lectures sort of showing some unknown cases with some questions, and we'll come back to these cases at the end. So this is obviously a axial T1, axial T2 fat SAT and post-contrast image of a lesion within the proximal thigh. So take a look at this, and based on the imaging findings, which of the following is the most likely diagnosis here? I'll show you the images again. Okay, so which of the following is the most likely diagnosis for that lesion? This is question 2. This is another lesion. I'm showing you a radiograph of the knee. The radiograph is obviously important, and then I'm showing you, axial T1, axial T2 fat SAT. This is the axial T1, axial T2 fat SAT, and then, pre and post contrast imaging of the knee here, showing a different lesion. And what's the most likely diagnosis here? Again, just the images here, and then the choices, which we'll come back to at the end of the lecture. And then the final question I wanted to ask you guys is, the differential diagnosis for a T1 hyperintense lesion that exhibits fat saturation on T1 fat SAT includes all the following except. Is it a lipoma, well-differentiated liposarcoma, hemangioma, mature ossification, or melanoma? Okay, so that's the third sort of philosophical question that I wanted to pose here. We'll come back to all those at the end. What I want to do here today is review the spectrum of the most common soft tissue masses in musculoskeletal imaging. I want to identify the characteristic tumors based on history, location, radiography, and MR. I think those are the four key features that we look for when we're evaluating tumors: the history, the location of the lesion, what it looks like on radiographs, and what the MR signal characteristics are. And we're going to delineate a systematic MR-based approach for workup of soft tissue masses. Okay, so the first thing we're going to do is we're going to review the spectrum of the most common soft tissue masses. In 2013, the WHO classification revised their classification of soft tissue tumors. And there's a lot of different classifications that you can see. But the interesting thing is that nerve sheath tumors, so schwannomas and neurofibromas, weren't part of the WHO classification of soft tissue tumors. They were added here, as were just tumors as well. And then also another important change that occurred is, the most common soft tissue mass in musculoskeletal imaging was known to be an MFH, or a malignant fibrous histiocytoma. That's now known as a undifferentiated pleomorphic sarcoma, which is here in category 12 here. An undifferentiated pleomorphic sarcoma is the, I guess, the more proper term now to describe what was previously called a malignant fibrous histiocytoma. You can see there's a vast array of different soft tissue tumors that we see. Soft tissue tumors obviously are tumors that consist of soft tissue elements, so things like fat, muscle, blood vessels, fibrous tissue, etc. So that's what we mean when we're talking about soft tissue tumors. And again, we're not talking about bone tumors in this lecture. That would be a totally separate lecture. So these are all masses that occur within either the subcutaneous fat, the fascia, the muscular planes, etc. The interesting thing to also know is that the WHO classification identifies lesions as benign, malignant, or indeterminate. Okay, benign, malignant, or indeterminate. And what we mean by indeterminate is something that is, either locally aggressive or it metastasizes, but very rarely. So less than 2% of the time it metastasizes to, other parts of the body. So that's what we mean by indeterminate. And another, I think, important point to note about lesions that are benign versus malignant is just how common benign lesions are. So if you're looking at 101 lesions, 100 of them are going to be benign. So that it's a 100 to 1 ratio for lesions being benign over malignant. Okay, so that's a really interesting ratio. And it's an impressive ratio, and one should be aware of that. Malignant lesions are much, much less common. They tend to be a lot deeper within the soft tissues, and they tend to be large. So less than 5% of lesions over 5 centimeters are benign. Okay, there's obviously exceptions to that rule, but in general, malignant lesions tend to be very large and very rare. Benign lesions tend to be smaller, and they're much more common. Okay, obviously the most common benign soft tissue tumor that we see on a day-to-day basis are lipomas. We see this all the time when we're doing ultrasound exams, CT exams, cross-sectional imaging. Fibrohistiocytic tumors are also pretty common. And obviously the most common sarcomas or malignant soft tissue lesions are, the undifferentiated pleomorphic sarcoma, which was previously known as an MFH. Okay, so 75% of sarcomas constitute the diagnoses that you're seeing here on the screen here. So some things are not included in the WHO classification. So for example, Morton's neuroma, which is known as, which is referred to as, perineural fibrosis of the plantar digital nerve, typically in the foot, in the second or third interspace. That's not part of the WHO classification. A ganglion cyst, which is the most common mass in the wrist, is not part of the WHO classification. Hematomas and anomalous muscles are also not. Okay, there's a wide spectrum of tumors that we're not going to get into, but there's different categories and classifications. It's a very wide array of tumors that we talk about in general. So now let's go ahead and talk about, the different characteristic tumors. And I think that imaging really does play a limiting role in differentiating benign versus malignant lesions. There are oftentimes we cannot tell whether something is benign or malignant just strictly based on imaging. We can favor, a benign or malignant etiology, but we can't always tell. And that's why we oftentimes, if we don't know what something is, we often have to biopsy the lesion. Some lesions are characteristic, though, based on the history, the location, what it looks like on X-ray and what it looks like on MR, right? So, for example, if you saw a mass, a fibrofatty mass within the, along the inferior tip of the scapula, deep to the rhomboid muscles, that's most likely going to be a elastofibroma. If you saw a mass, a teardrop-shaped mass, in the second or third interspace in the foot in a female that wears high heels, that's likely going to be a Morton's neuroma, right? So there are certain masses that tend to be very characteristic based on history and location. A liposarcoma would be something that would be very rare in a child, but it's very common in adults, right? When there's history of trauma, you always want to think about, myositis ossificans or a hematoma. Mobile masses tend to be more benign, fixed masses tend to be more malignant, but there's always exceptions to all rules. Okay, so, in terms of location, these I think is a very succinct representation of, why location is important, because again, we talked about the elastofibroma. If it's along the inferior tip of the scapula, that's what that lesion is going to be. A glomus tumor, which is, a very hypervascular mass, is usually associated with a nail bed along the tufts of the fingers. A Baker cyst is always going to be present along the posterior medial aspect of the knee between the medial head of the gastrocnemius and the semimembranosus tendons, okay? Also known as a popliteal cyst. A plantar fibroma is going to be associated with a plantar aponeurosis along the plantar aspect of the foot, and a Morton's neuroma we talked about already. Okay, this is what an elastofibroma looks like. It's this sort of fibrofatty mass deep to the rhomboid and serratus muscles along the inferior medial tip of the scapula. They tend to be bilateral. They can be bilateral in 25 to 50% of cases. So you always want to look at the other side to make sure that there's not another a lesion. So symmetry is not really going to help you in this case. If you're not aware that there should be nothing, there should only be fat interposed between that area. So this is what an elastofibroma looks like. And radiography, radiographs are very important when we evaluate soft tissue tumors, and the reason for that is because we want to look to see if there's any mineralization. Are there soft tissue calcifications? Is there ossification within this tumor? What is it doing to surrounding structures? Is it remodeling the bone? Is it distorting fat planes? Are there radiolucent areas to suggest a lipoma? So those are some of the questions that you should ask yourself when you're looking at a radiograph. Is there soft tissue swelling? Can you see the actual soft tissue prominence? That's the type of information we can get from radiographs. And this is, a beautiful example of what a lipoma looks like on a lateral view of the elbow. You can see this large radiolucent soft tissue mass suggestive of a lipoma. Okay, so we can make that diagnosis even on a radiograph. We don't necessarily need an ultrasound or a CT scan. Okay, this is an example of a synovial sarcoma. Okay, so this is obviously a misnomer. It has nothing to do with a synovium, but 15 to 30% of these can have calcifications or mineralization as seen in this radiograph here. So that's where it can help us. And this is, this turned out to be a synovial sarcoma here. Okay, typically seen in younger individuals. It's a malignant lesion around joints, but not necessarily within joints. Doesn't necessarily have to do with the synovium. MRI, though, is the best imaging modality to assess soft tissue tumors. And the reason for that is because of the high soft tissue contrast resolution. We can see all the muscles, the tendons, the ligaments. We can see how well it's distorting fat planes, if it's impinging underlying nerves, neurovascular structures. We can see, if there's any tumor necrosis, hemorrhage. It's very important for preoperative planning and for staging of the tumor. And that's why MRI is the gold standard for evaluating soft tissue tumors. Okay, and now what I want to do is, for the remainder of the bulk of this talk, is talk about how we evaluate soft tissue tumors and how the signal intensities on T1 and T2 can help us at least come up with a succinct differential diagnosis for evaluating soft tissue tumors. So, for example, if on T1 the lesion is hypointense to skeletal muscle, that doesn't really help us because a lot of lesions tend to be dark or hypointense relative to skeletal muscle on T1. But if the lesion is hyperintense on T1, if it's bright on T1, that can help us a lot. That can really limit our differential. So there's only a few things that are bright on T1, and that's fat. Things like a lipoma, protein, melanin, and hemorrhage, right? Obviously, GAD is bright on T1, but we're not going to be looking at GAD on a pre-T1 image. Okay, so fat, protein, melanin, and hemorrhage are going to be bright on T1. And this is sort of an algorithm that you can find. And by the way, all these algorithms that I'm going to show you today are from a radiology article written by some of my mentors, Dr. Jim Wu and Dr. Mary Hawkman, who actually trained me as a fellow at the BIDMC. They wrote an excellent article on soft tissue tumors, and these algorithms are based off of their article in radiology. So obviously, I don't want to take credit for their beautiful work. So. T1, if something is T1 or hyperintense on T1, the first thing you want to ask yourself is there fat suppression? Because if there is, it's likely the lesion contains fat within it. Okay, so if it does, then you're going to ask yourself, are there calcifications within it? Because if there are, then it could be something like a hemangioma, because those calcifications could be phlebolus and fat can be present in a hemangioma, or it could be myositis ossificans that's mature, because you can have calcifications that are mature that'll eventually ossify, and there is fat within myositis ossificans because bony constituents have red marrow and yellow marrow, and that yellow marrow tends to be fat. If there aren't any calcifications, or there's no mineralization associated with the mass, then you're likely dealing with either a lipoma variant, well-differentiated liposarcoma, or even a hemangioma. Not all hemangiomas have to have calcifications, and they can certainly have fat in them, or other fat-containing lesions. So the first question you're going to ask yourself is there fat? If there is, you're going to go down this differential. If there's not fat, if it's hyperintense on T1 and it does not suppress with fat saturation, then it's either going to have methemoglobin, which would be like a hematoma with or without tumor. Tumors can have hematoma within them. It could be proteinaceous fluid, such as a ganglion or an abscess, or it could contain melanin in the case of a melanoma or melanoma metastases. Okay, so that is sort of in a nutshell how you're going to evaluate T1 hyperintense lesions. Is it fatty? Yes or no? And then you're going to go down to your differential. If it doesn't have fat, then it either contains methemoglobin, protein, or melanin. Okay, so that's an important algorithm that you want to be aware of. This is what a lipoma looks like. Okay, so it's going to be radiolucent on the radiograph. Okay, notice that it does nothing to the underlying cortex. It does not scallop the cortex. It does not remodel the cortex. It's bright on T1. This intramuscular lipoma is bright on T1, and it exhibits complete fat saturation on T1 fat saturation. Okay, there's not going to be any areas of nodular enhancement, no septal enhancement greater than 2 millimeters. Okay, to suggest either a atypical lipomatous tumor or a well-differentiated liposarcoma. We'll talk about those in a second, but this is just a simple lipoma with no aggressive features. Okay, a liposarcoma, which is the malignant the malignant form of a fatty containing tumor, can be seen if the septa or nodules are greater than 2 millimeters. If you have septations within the mass that are thicker than 2 millimeters, if it's more than 10 centimeters in size, if it's deep, if the lesion contains less than 75% fat, then you should be worried that this could in fact be a liposarcoma, okay, and not just a simple lipoma. So those are the worrisome features that you want to look for to make sure that either it's a simple lipoma or could this be a liposarcoma or a malignant fatty soft tissue tumor. Okay, so the WHO classification. So before, people used to differentiate between an ALT or an atypical lipomatous tumor or a well-differentiated liposarcoma. Now, according to the WHO classification, those are essentially the same thing now. They're used interchangeably. Okay, so if you start to see septations that are greater than 2 millimeters, If there's nodular enhancement in a predominantly fatty mass, it's likely an atypical lipomatous tumor, okay, or a well-differentiated liposarcoma. That's an example of one. A hemangioma, which can also contain fat, and it can be in the differential for both a lesion that contains fat or doesn't contain fat, essentially. Because of methemoglobin content, okay, potentially, looks like this. So you can have some fatty areas within the tumor, okay, but notice that there are these hypointense regions which are phleboless. You can see the calcifications here on the radiograph, which is helpful because this is a clue that there's some mineralization within this mass, right? But there is some fat here, so this is likely a hemangioma. Remember, some of it is can have fat in it, but there's all these phlebolous and flow voids within it, and there's all this vascularity coursing through the mass. So this is a case of a vascular malformation or a hemangioma. Okay, another very common mass. Myositis ossificans can also be pretty common. It's related to trauma. When you have a localized hematoma that demonstrates calcification, then ossification, and then becomes sort of a soft tissue ossified mass. The key to making the diagnosis of myositis ossificans is understanding that there's a zoning type of calcification, meaning that it's more pronounced and it starts more in the periphery and it's less pronounced centrally, okay? And bone is more pronounced peripherally and more pronounced centrally. That's in distinction to an osteosarcoma where the osteoid matrix mineralization is more pronounced centrally and less pronounced peripherally. That's a very important point. And it can be T1 hyperintense secondary to the bone or the fatty ossification associated with myositis ossificans. This is the typical characteristic zoning pattern of ossification that we see in myositis ossificans, where it's more pronounced centrally, more pronounced peripherally, less pronounced centrally. Okay, so this is a classic case of a myositis ossificans. Okay, you may be tempted to think that could this be a surface osteosarcoma because it's sort of abutting the cortex of the bone. But again, the zoning pattern is what's key here. So myositis ossificans can be very confusing on MR. Okay, it can have a wide different array of appearances. So for example, the X-ray was negative. You have this lesion that that was T1 dark, T2 bright. It enhances with gadolinium. This could look like a sarcoma. I mean, that's those signal characteristics appear similar to what a sarcoma would look like. T1 hypointense, T2 hyperintense, and enhancing with contrast. However, if you look at the lesion 3 months later, you notice that there's T1 bright signal along the periphery, which could be mature ossification that contains fat. It's dark on T2, okay, and it shows rim enhancement. So that's characteristic of myositis ossificans. Okay, it can be very difficult to evaluate. A lot of times these get biopsied and they come back as myositis ossificans. So it's a very confusing diagnosis on MR, especially if you don't have the history, which in fact a lot of people don't give you the history of trauma in the past. Okay, so this is the algorithm for T1 bright lesion. I just want to show it to you again. I'm going to show you these consistently so you kind of get it in your head. So these are what we look for. The first question you're asking is there fat suppression? Okay. Now, obviously, things that are T1 bright, you can have methemoglobin, right? And you want to follow that to resolution to make sure there's no mass associated with that hemorrhage. Proteinaceous fluid can look like, a ganglion or an abscess, and then melanin, which is melanoma. These are all lesions that are T1 bright, but that they don't suppress with fat. So this is an example. It's a T1 bright lesion, and on the fat side, it does not suppress with fat. So it could be any one of these 3 lesions, okay? So T2 hypointense lesions are also very helpful. If a lesion is dark on T2, that can be very helpful, okay? Because usually those lesions are lesions that either fibrous, they contain hemosiderin, which is a different type of hemorrhage, right? Methemoglobin is a different type of hemorrhage, but hemosiderin is a different type, or calcifications, okay? So fibrous lesions containing hemosiderin, or calcifications. Those are the 3 things that you should think about when you have a T2 dark lesion. Now, I do want to say that calcifications can be variable on MR because based on the hydration of the protons and the mobility of the protons, calcification can either be hyperintense or hypointense. So depending on that mobility of the protons within, the calcifications, the signal characteristics can be different. Okay, so, and again, also not all fibrous masses are T2 dark. They can be bright, they can be intermediate in signal intensity, so that's an important point to remember. But this is the algorithm that I want you guys to remember if a lesion is hypointense on T2. And that is, you want to first ask yourself, are there calcifications associated with this, T2 dark lesion? Because if there is, and that means that there's some sort of calcification within the mass, and that means that it's either dystrophic calcification, or gouty tophi can also look like that. It can be dark on both T1 and T2 when you have gouty tophi associated with gout. However, if there are not calcifications, then you're really looking at a tumor that either has hemosiderin or fibrous tissue. Okay, so if it's fibrous, it can be a giant cell tumor of the tendon sheath, a plantar fibroma, elastofibroma. If it contains hemosiderin, then it's likely something that contains hemorrhage, PVNS, or even a giant cell tumor of the tendon sheath. Notice that giant cell tumor of the tendon sheath can be dark on T2 for two reasons. It can either because it has hemosiderin or because it has fibrous component to the tissue. Okay, so giant cell tumor of the tendon sheath is actually in both of these differentials. Okay, but that's really, if something is dark on T2, you should be thinking about masses that have calcification, fibrous tissue, or hemosiderin. That's the pearl associated with T2 hypointense lesions. Okay, so things that have dense calcification can be either dystrophic calcification or gouty tophi. This is just an example of gout where you have soft tissue tophi here. You have juxtaarticular erosions. Okay, so it's characteristic of the first MTP joint in the great toe. Fibrous tumors can be anything elastofibromas that we talked about, a giant cell tumor, a fibroma. This is a great example of a giant cell tumor of the tendon sheath. Notice that it's sort of dark on T1, hypointense, and although the majority of the lesion is actually bright on T2, there are hypointense foci within this lesion, which is important. That means that there's either hemosiderin, fibrous component, or calcification. But the key to this case is that it's intimately associated with this flexor tendon. Okay, about the toe. It may actually be associated with the abductor. No, it's actually associated with the flexor hallucis longus here. Okay, so this is a classic example of a giant cell tumor of the tendon sheath. Okay, hemosiderin, right? If it has hemorrhage within it, it can be PVNS, a hemorrhagic mass, or even giant cell tumor of the tendon sheath again. Okay, so this is an example of PVNS where you have these soft tissue masses that you can appreciate on the plain film. They're not remodeling the bone, but they can. They can remodel the bone. Maybe they're slightly scalloping the anterior tibial plafond here on the MR, but on the plain film it's hard to appreciate that. But they're usually hyperdense masses or radiodense masses on plain film, and then they tend to be dark on T1. They'll have some dark foci on T2 as well. Okay, and they can definitely cause pressure erosions. And on the T2 fat cell, you're going to see some hypointense foci within it. Okay, so this is characteristic of PVNS, which is proliferation of hemosiderin within the synovium. Okay, so this is a case of PVNS, and they can avidly enhance on post-contrast imaging. Okay, so again, T2 dark lesions, you want to think about calcification, hemosiderin, or fibrous tissue. If a lesion is T2 bright, okay, that's non-specific, but it is also helpful. And the main thing you're looking at if a lesion is T2 bright is if there's enhancement, okay? Because if there's not enhancement, it's a cyst. If there is enhancement, it's a mass, okay? So that's the main thing. So you're looking at the enhancement pattern. If there's just rim enhancement and no internal enhancement, it's a fluid-containing lesion. It's something like a ganglion, a seroma, an abscess, an epidermal inclusion cyst. Those are things that you want to look for. If there's solid internal enhancement in a lesion that's T2 bright, then it's essentially some sort of sarcoma. Okay, some sort of sarcoma, an intramuscular myxoma, or a peripheral nerve sheath tumor. I mean, essentially, that's what it is. That's what it is. Okay, so if a lesion has solid internal enhancement and is T2 bright, it's some sort of sarcoma, some sort of intramuscular myxoma, or a peripheral nerve sheath tumor. Okay, that's the three things that I want you guys to think about. Okay, so with peripheral rim enhancement, it's likely a fluid-containing lesion, as we talked about. Okay, so this is just a classic case of a ganglion cyst. Okay, it's T2 bright and has peripheral rim enhancement, no solid internal enhancement. Okay, they tend to be associated. They can be associated with joints. Sometimes you can see a neck that is associated with a joint or a ligament or a tendon. That doesn't always have to be present, but that can be present. Usually, they're around joints, tendons, or bursae. When you have a T2 hyperintense lesion that has solid internal enhancement, it's either a myxoma, an intramuscular myxoma, a peripheral nerve sheath tumor like a schwannoma, neurofibroma, malignant peripheral nerve sheath tumor, or a sarcoma, some sort of sarcoma. That's the general differential for that. And these lesions, by the way, tend to be T1 dark or hypointense as well. Okay, so this is a myxoma. This was actually one of the index cases that I showed at the beginning. There's this mass here within the vastus lateralis, right? It's T1 dark, T2 light bulb bright. Okay, that's another clue. Myxomas tend to be T2 light bulb bright within the muscle, and there's heterogeneous enhancement. This is a myxoma. This could have been a sarcoma. This could have been a peripheral nerve sheath tumor, right, associated with the sciatic nerve, but in this case, this was a myxoma. Okay. So MR signal characteristics are very important, right? That's what I focus on this lecture. But there's also other important things that I didn't talk about, which why MR is important. So you want to also assess the homogeneity or heterogeneity of the lesion. You want to assess the enhancement pattern, how much is enhancing, where is it enhancing, is there a perilesional edema associated with it, what the size is. And one of the key things that everyone should talk about in their reports is, invasion of important structures like neurovascular structures. Is it impinging on the sciatic nerve? Is it impinging on, the neurovascular bundle? Because that's important for preoperative and surgical planning as well. And, that can explain some of the patient's symptoms as well. And is there necrosis? That's important for staging. How much necrosis is there? How much hemorrhage is there, etc. Okay? So, in conclusion, what I want to say is that MR is very helpful in limiting the differential diagnosis based on the signal intensity characteristics, especially if something is T1 bright or if it's T2 dark or T2 bright. We can have a limited differential. But often we can't necessarily tell exactly what the lesion is. So even if something is, T1 dark, T2 bright and enhances, remember, the differential is, a myxoma and a peripheral nerve sheath tumor, which tend to be more benign, but it could be a sarcoma, which is malignant, right? So we can't even tell based on the signal characteristics if it's benign or malignant. It gives us a nice differential, but we can't always tell if it's benign or malignant. So ultimately, if you can't determine if a lesion is benign or malignant, they often have to undergo biopsies, which is what we do all the time. We have a busy sarcoma service here at University of Maryland, and I tend to, we biopsy, 3 to 5 lesions on a weekly basis. Okay, so that's what we do. So I just want to come back to the questions here. So this again is, this is, a lesion here in the thigh within the vastus lateralis. It's T1 dark, T2 bright, and it has heterogeneous enhancement. So again, these lesions, because there's internal enhancement here, it's going to be, it's not going to be a cyst. It's going to either be a myxoma, a peripheral nerve sheath tumor, or a sarcoma. And the only one that fits that here is B, a myxoma, right? A fibroma would be T2 dark, or have some sort of hypointense signal. A lipoma would be T1 bright. A ganglion wouldn't have solid enhancement, and a giant cell tumor would also have some element of T2 hypointense signal. So the only answer that makes sense here is a myxoma, okay? So here's another lesion here. Notice again, there's some calcifications or mineralization on the plain film. There's a mass here that is predominantly T1 dark, but there is some hyperintense signal here. There's, marked, T2 bright signal, tubular structures that are demonstrating enhancement. These are flovoids. These are, these are phlebolus in the case of a hemangioma. Okay, so this is a vascular malformation. Okay, so that's the answer here. And then finally, the differential diagnosis for a T1 hyperintense lesion. Okay, so it's bright on T1 and it exhibits fat saturation. Okay, so that means it has fat. So a lipoma has fat. A well-differentiated liposarcoma usually has fat. A hemangioma can have fat. Mature ossification has fat. But a melanoma does not have fat. So the answer here is E. A melanoma is not going to exhibit fat sat on T1 fat sat images. Okay, so hopefully what we've done here in less than 30 minutes is describe the spectrum of the most common soft tissue masses in MSK imaging. We identified the characteristic tumors based on history. For example, elastofibroma being along the inferior tip of the scapula, location, radiography, and MR imaging, and we talked about a systematic approach based on signal characteristics on MR. And these are the diagrams or the algorithms that I talked about earlier. If something is T1 bright, again, it could be fat, melanin, protein, or hemorrhage. Okay. If something is dark on T2, it's either calcification, hemosiderin, or fibrous tissue. And if something is bright on T2, okay, the key question you're going to ask is, what's the enhancement pattern? If it's rim enhancement, it's likely fluid. If there's solid internal enhancement, it's likely a mass, either a myxoma, peripheral nerve sheath tumor, or a sarcoma. Okay, so I hope that was helpful. This again are my references. Again, Dr. Jim Wu and Mary Hawkman wrote this amazing, incredible article in the 2009 issue of Radiology, which is where I took these algorithms from. Please read it if you haven't read it already. It should be mandatory reading for all musculoskeletal radiologists or residents that are trying to understand MSK radiology. And I obviously use StatDX as well. Okay, so thank you so much for your attention. If you have any questions about this, please feel free to email me. Thank you so much.